Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London, and I'm the chair of the BTOG steering committee.
And I'm Emma O'Dowd. I'm a respiratory physician from Nottingham, and I'm a steering committee member alongside Tom. And this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers.
Now, it's important to say that sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything we discuss today. Hello, everyone. Welcome to another BTOG podcast. We are continuing on our theme of this mini-series of stage 3 disease, and we've now come to the exciting area of surgery. And I'm delighted that joining Emma and me is Sofina Begum. Sofina is a consultant thoracic surgeon at the Royal Brompton Hospital. And I have the pleasure of working with her every week, which is fantastic. Sofina, welcome to our podcast. Not the first one that you've done, actually.
Oh, thank you for having me.
You're going to get invited back, and there can be no higher praise than that. So just to set in context where we are, as I said, we're in the locally advanced disease setting for our audience, and that really is patients with stage 2B to stage 3B disease, roughly speaking. So not metastatic disease, not early stage disease. And we are going to be talking in next podcasts about systemic treatments and future podcasts about radiotherapy. So here very much we're going to focus on surgery and its role in that context. So I'll hand over to Emma for the first quizzing.
Yeah, thank you so much for giving up your evening. So I think it would be perhaps important to start first of all with how we think that surgery has changed, certainly in the past few years, and with the era of perioperative therapies, both for you and within the whole country, basically.
So surgery in now is the majority of lung cancer surgery in the UK is done by a minimally invasive approach, whether that's VATS or RATS. Okay, and this has really helped us decrease the mortality and morbidity associated with surgery. Traditionally, surgery, but the majority of surgery in the UK for lung cancer is now done by a minimally invasive approach. We're in the era of enhanced recovery. This again has led to improvements in mortality and morbidity associated with surgery. Where there is prehabilitation available, that has again has resulted in improvements in mortality and morbidity associated with surgery.
And do you think that in this perioperative era, we very much see that centres are sort of judged on their minimally invasive lobectomies and the proportion of patients who have minimally invasive surgery? Do you think that as we're pushing this sort of boundary into the perioperative neoadjuvant setting, that actually the number of open surgeries may actually go up again if we're looking at trying to give these patients optimal surgery?
So I think we are obviously scrutinised for the percentage of resections we do via a VATS or a RATS approach. And that's correct. Okay, early stage lung cancer preferentially should be done by a VATS or a RATS approach. But locally advanced lung cancer, generally, if you're going to do an extensive resection, then open surgery gives you usually better access. Okay, that's not to say that it's not possible to do it via a VATS or a RATS approach, but you need to be careful about case selection. You need to think about how neoadjuvant or preoperative treatment is going to affect your planned procedure. And certainly these patients, even if you were planning to do these via a VATS or a RATS approach, you would consent for a higher conversion rate.
And I think
I'll put my hand up and ask a really annoying question. Sorry, I must jump in. Can you just explain, Sofina, what a RATS is for oncologists like me who don't understand these things?
Sorry, it's not a rat running around in theatre. It's a robotic assisted approach procedure. So it's where you've basically used a robot instead of just using the instruments yourself.
Thank you.
And the advantage of the RATS approach over the VATS approach in terms of visibility and resection, what is the advantage when you're doing a resection with a robot?
Visibility is much better. Okay. And in terms of handling, it's better. But in terms of actual data backing that up, we don't have any data that suggests rats is better than VATS.
But there is obviously an increasing proportion of centres that are doing rats.
So if you were doing multi-station, if you're doing lymph node dissection and you're doing multi-station lymph node dissection, then that is better via a rats approach rather than a via VATS approach. So
in our locally advanced setting, it may be that actually a robotic or an open approach may be the approaches we're talking about for these patients rather than a simple VATS. It's really with the locally advanced disease, I think each individual patient is completely different. Where you've got disease, say particularly if you're clearing out a station 7, the lymph nodes, Tom will know my preference will be I want to clear right down to the contralateral bronchus. I want to feel the other side of the left. If I'm doing a right-sided procedure, I want to make sure that I can feel the left-sided bronchus and it is clean. So my preference in that situation is to do a thoracotomy. I don't see that changing for station 7 disease. It may change for other disease. I think I would assess each individual case on what I'm trying to achieve with the resection. And I think that probably then goes on to how we look at monitoring centres, because actually it may be completely appropriate that the number of open operations is actually going up in the context of a different case mix, patients who previously wouldn't have had surgery potentially. Although we're going to come to that a bit later about how we select some of those patients as well, I guess.
I think the more interesting thing, the way to look at it is the percentage of cases that are done minimally invasively depending on the stage of lung cancer. For a stage 1, stage 2 lung cancer, you would expect the rate of the number of procedures done by a VATS or a RATS approach to be high. Okay, you would not expect those patients to have a thoracotomy. Whereas you do then separately want to look at how many stage 3 patients are you operating on, and of those, how many are done. And I think of the stage 3 patients, I don't think we should scrutinize how many are done VATS and how many are done open, because the risk we run is, the first thing is it'll make people risk averse. They'll turn it down. The second thing is, if it's a trade-off between an R1 resection and an R0 resection, and the danger here is people trading off that, and they should not be. Your goal, especially with the stage 3, if you're taking on a patient with stage 3 disease, you need to get the R0 resection. And if that means you need to do a thoracotomy, do the thoracotomy. You don't want to put people off doing a thoracotomy just because you're going to scrutinize their thoracotomy figures.
Yeah, and I guess that comes then to us discussing resectability and operability, doesn't it? And I know I think Tom can start by asking a few questions about that.
Yeah, I mean, when we sit in the MDT, we talk about, is it operable? But I know, Sofina, even I know there's a difference between being operable and being resectable. Can you just explain to people what the fundamental difference is?
So resectable is basically our ability to remove the tumor with an R0 margin. Okay, and that's traditionally how it's been defined. The consensus statement that came out from STS earlier on this year defined it slightly differently and suggested that actually it should be not just are you technically able to remove the tumor, but are you technically able to remove the tumor, and is that appropriate? So considering the biology of the tumor, the effectiveness of alternative therapies. So taking into account all of that, is this tumor resectable? And then operability is very much about the patient being fit enough for the procedure. So yes, I could do a bilobectomy, take a tumor out, but actually that patient may not be fit for that procedure. So assessing, can the patient withstand the extent of resection you're planning.
And when I'm as a respiratory physician working someone up, what I obviously want to do is bundle my tests. And what tests do you need to decide if someone is, I guess, resectable, first of all, and also operable?
So in the bare minimum is lung function tests. Okay, lung function tests, the PET scan, the CT scan. Ideally, in a locally advanced tumor, I want a CT with contrast. Okay. I don't mind if the patient comes with that CT contrast or if I book the CT contrast, but either way, I'm going to get that.
And why would you specifically, just for people listening, why would you want that contrast on board? Because I mean, we do have patients coming through screening who perhaps have had a non-contrast scan.
They will have had a non-con scan.
Yeah.
But if you're trying to identify lymph nodes, you're trying to identify lymph node anatomy, you're trying to separate invasion, then you need the definition that intravenous contrast will give you. Then I would say the rest of the investigations really is individual patient dependent. My threshold for getting an echocardiogram in this group of patients is quite low if I'm planning an extensive resection. Tom and I have been caught out by this on a couple of occasions where I've done the echo late and I'm like, oh, that they're not fit for the planned resection. And actually, I've learned now that if I'm considering an extensive resection, get the echo up front and make sure they're good. It's good because obviously they're risk factors for ischemic heart disease and for lung cancer, shared risk factors.
Yeah. And you touched there on those kind of rules from the SCTS, Society of Cardiothoracic Surgeons, about resectability. How generalizable are they? If you were to take 50 surgeons and show them, I don't know, 3 different cases, is everyone going to agree, or does it come down to
No.
how good your hands are?
No, it's not even just how good your hands are. It is local expertise. So how much of this do you do? And I think that is important.
Yeah.
Like how much have you done? How much do you do as a unit? But also the support you have within the unit. What if I'm going to take on a patient who is perhaps a very high risk, then I will always put them through the high risk MDT, where there's an intensivist radiologist and HDU person, and everybody will discuss that patient. All of the surgeons dial onto it. So we have a consensus statement. Yes, we agree with the decision. Although the MDT has made a decision for surgery, we will agree, yes, they are fit for the surgery, but we will put some safety measures in place. So with a lot of these patients, HDU will say, right, I want this done. I want physio to see them pre-op. I want the dietitian to see them. I want speech and language to see them. Or I want the pain team to have already kind of put a plan in place. And these things really safeguard us and the patient, and it means that you're prepared for that high risk patient. Your outcome is that much better.
Do all centres have that, or is that going to be the preserve of larger centres which have the resources and the numbers to do that?
I know not all centres have a high risk MDT, but the larger centres do. I know we do. I know guys do. I think quite a few of the bigger centres do. And really, it does help you in managing these patients and optimizing them prior to surgery. Yeah. Some centres do have a pre-op preparation clinic that is run by general medicine, which kind of optimizes those complex patients prior to surgery, and that's a very good resource.
Interesting. And so I get completely that you can't define in a single sentence what is resectable. Are there any golden rules? Are there any aspects where every surgeon pretty much is going to say, look, that's not resectable? Can you give me any examples of that?
So multi-station bulky end tube is clearly not resectable. Okay. But also I would say that if you're considering a pneumonectomy in somebody with, even if they've got resectable N2 disease, a pneumonectomy is a big procedure to put patients through, because what you've got to remember is they've then got to be fit for adjuvant treatment. Okay.
Although interesting, in the trials, quite a few people got pneumonectomies, many more than you and I see in our West London practice, right?
So it's interesting because the pneumonectomy rate in the trials was as high as 25%.
Yeah, we never see it.
The UK registry data shows that the pneumonectomy rate in the UK is between 3 and 5%.
Yeah.
It's very, very rare that we do a pneumonectomy. And I don't feel that that is a trade-off with our resection margin. It's not. I mean, the other thing that was surprising from the trial data was the R1 and R2 resection rate. It's very unusual.
Just to come back to that pneumonectomy, is that a cultural difference in other countries where pneumonectomy is done more? Are we an outlier in doing fewer, or what's going on there?
I don't think we're an outlier. I think a pneumonectomy is appropriate, but in a very, I would question a pneumonectomy rate of 20%.
Okay.
That to me is you're not careful enough in your case selection. So
bulky multi-session N2 disease, most surgeons would say not resectable. Requiring a pneumonectomy, lots of surgeons would say not resectable.
Pneumonectomy in the presence of N2 disease.
In the presence of N2 disease, yes, sorry. Yeah.
Okay. Pneumonectomy by itself, where you've got even just single station disease or N1 disease, that's fine. Go for it.
Got you. An invasion of mediastinal structures, is that an absolute no-no?
If you're saying invasion of, say, the pericardium, invasion of the diaphragm, invasion of the chest wall, I think these are all, this is all individual patient dependent. Yeah. And in a young, fit and well patient, this would not bother me. I would say go ahead and resect, especially if they are fit for chemo IO up front. Give them the chemo IO, do the procedure, because these patients have the most to benefit.
My last question about
No.
My last question about resectability before I hand over to Emma is, you mentioned R0.
Yes.
Why is that so important? And you mentioned there in trial data, people having R1, even R2 resection. From a surgical point of view, it's so important, isn't it? Can you explain to us why it's so important?
I think my view on this is pretty much the same as most surgeons. If you are leaving disease behind, to my mind, it's the same as not doing the procedure.
Yeah.
Because you've left disease behind. You should not be doing you should not have an R2 rate. So just for clarification, R2 is when you've macroscopically left tumor behind. Yeah. Okay. And I would argue in that situation, you should close that patient, because the thing that will make the difference to that patient is getting to chemotherapy, getting to SACT. If you take out even like a lobe, okay, their recovery time is going to be prolonged, and their time to chemotherapy is again going to be prolonged. So actually, you're slowing down their treatment pathway. You've done them harm by doing that resection. Okay. So I think it's, intraoperatively using frozen section, making sure your margins are negative, checking your nodes, checking, as far as possible that that you've got an R0 resection. There are things that you cannot help. Okay. You've got, extra capsular spread on a lymph node. You've got a pleural effusion, which subsequently turned out to be positive, because you're not going to get intraoperative frozen section and frozen section cytology. That's not going to happen. So these things you can't do anything about.
And I guess in these patients, you don't want to have very, very long pathways, which allows patients to progress before they come to surgery, I guess, as well.
Yes.
And in terms of operability, we did sort of touch on it. Obviously, we have our sort of bundle of physiological tests that we see, but obviously me as a respiratory physician, when do you want me to send them to you to say, is this person operable? At what point of us kind of working them up?
So my preference is to see them at the front of their pathway before they start their their neoadjuvant chemo IO. I like to see them. I like I need to eyeball them, do a functional assessment, just check that I think that that patient is going to be fit at the end of chemo IO for surgery. It is a useful window because in some of these patients, that chemo IO window has allowed us to refer to for virtual pulmonary rehab, and offset some of the functional decline they're going to have during chemo IO by putting them through rehabilitation, prehabilitation at the same time.
And in terms of the patients who've been quite borderline, have you had quite positive experiences with a prehabilitation service in terms of
Rehabilitation where it's been available has been great. Okay. The limitation for us has been availability of a really good prehab service. We have we're reliant rather than the ideal situation would be if you had a pre-op preparation clinic. We're not that fortunate. So we end up doing individual referrals. So doing a referral to clinical psychology, to SALT, to dietitians, and just making sure these patients, a lot of them have dietary insufficiencies and could be optimized. So this is all taken care of during this period.
And in terms of your experience, you mentioned about getting echoes up front because of this cardiac disease. Is that the main reason why you found that patients are not operable, or is it often respiratory disease that makes them non-operable that we haven't kind of twigged severe enough?
The respiratory disease at the moment has not stopped me. The two that I've had, it's been cardiac disease that has prevented me offering surgery.
So actually for us, it should be that we're also looking at that whole cardiac, whether there's something that we can optimize or assess early on in the process as well, just to make sure we're not sending someone down an operative route who is not operable.
Generally, when you've seen somebody in a clinic, okay, and by you I mean the respiratory team, you will have looked at performance status, you will have looked at lung function results, and you'll have had a CT scan. There is very little lung disease that you're going to miss with those three investigations. The thing that you're going to miss is the cardiac history. And cardiac history can sometimes patients don't see it as a problem and they won't have mentioned it to you.
Yeah.
And sometimes you're not going to pick it up because it's quite subtle. So actually, in my patients who are going to have chemo IO, I will get a baseline echo.
And do you do many cardiopulmonary exercise tests in people?
So I do, but it's not a common test. I tend to walk them in clinic myself.
Mm-hmm.
I'm just thinking about the patients who don't get to surgery. There's an excellent poster in BTOG 25, in fact, looking at patients who didn't get to surgery and what did they have instead. And interestingly, the percentage of patients who didn't get to surgery in real world was very similar to that in the trial. It's about 20%. And the commonest cause was disease progression. And the next commonest was cardiac. And then I think it was respiratory. But it's interesting, isn't it, that I think when you go down that route of neoadjuvant chemoimmuno, we've got to say to people, we want you to have surgery, but I can't promise you will. And yeah, Sofina's mentioned, we've been called out a couple of times over the past couple of years, haven't we?
Yeah. I guess it's about counselling people up front, isn't it? That this is the intention. However, there is always a risk associated with this approach. And I think we're probably going to touch a bit more now on this sort of perioperative chemoimmunotherapy patient group.
So Sofina, the arrival of chemoimmunotherapy has made a huge difference from the oncology point of view. It's a massive part of what we do now. What is the view of you and your colleagues at Brompton, for example, of surgery in this context? Is it something that you welcome and embrace, or is it something that's been very challenging and you try to avoid as a group?
So I definitely do welcome it because it's such a big, the benefits of it are amazing. yes, it's a challenge, but that doesn't mean you're not going to welcome this challenge. It's challenging in that the surgery can be more difficult because they've had a reaction to chemoimmunotherapy. There's a lot of exudate. There's a lot of, tissue. You just think, is that tumor? Is that not tumor? Or is that just response to chemotherapy? And you're not sure. The thing I have learned is I definitely use frozen section more in those cases, just because I can't obviously tell visually, is that tumor or is that not tumor? So for all of those cases, I will have frozen section booked. Some patients, when you go in, you plan a VATS procedure and you're able to complete VATS, it's fine. And there's very little, you can't see that there's obviously a difference with the chemotherapy. Other patients, it's been a very, very kind of different situation. There's a lot of fibrosis, a lot of scarring. It's very difficult to define anatomy. Tissue planes are completely altered, and it's not always a very enjoyable procedure. But it's strange because I'm thinking of two particular patients who had a complete pathological response, and those were the two cases where I found the procedure the most difficult and challenging.
And is that borne out, all those changes you've seen at surgery in someone who I've been mucking about with chemo immuno, is that shown in the clinical trial data? Is that reflecting what you're finding in real world, or are you and your colleagues discovering things that have not been necessarily flagged up in those studies?
The surgical data or the technicalities of the surgery weren't really discussed extensively in the papers.
No, they weren't, were they? They made the complication rates and duration of surgery and blood loss. It was pretty, even by my standards, pretty basic assessment.
And it would have been nice to get like more kind of information about the technicalities of the surgery. What did they find? Did they have a higher conversion rate? Did they find tissue planes were altered? Did they find what we find, that actually the more response you've seen to the immunotherapy, the higher the rate of major pathological response or complete pathological response, because that's what we've seen in practice. Actually, those patients are more likely to have had MPR or a CPR. So
yeah. And so things I've heard from few people over the past few months and couple of years is what you see at surgery can be very misleading for what you then see in the pathology. As you've said, we've had a couple of patients where you phoned me up saying that was horrific. They never send someone to me like that again. And then we've looked at pathology a week later and it's a PCR. And we've also seen ones where you've gone in saying they've got big bulky disease. I'm really worried. I don't think it's shrunk down, and then actual pathology comes back saying it looks great. And conversely, we've had people where we thought we've done well, but actually they haven't. So it's quite difficult to predict, even at surgery, isn't it?
It is, because chemo IO, the thing I've learned is it completely destroys your reliability on your eyes.
Does it?
You can't rely on what you're seeing visually anymore, because it doesn't correlate at all.
Yeah.
So I can think of like one of the first patients I operated on. I did a rigid post-chemo IO. I did a bronch at the start of the case, and I looked at the airways and I was like, bloody hell, is there extensive endobronchial disease here? And I was like, that shouldn't be the case. So I took mapping biopsies just to check. I had to wait like 5 or 6 days for those results, and they were all negative. So actually the visual appearances did not correlate at all with the pathology. So this is what I've learned, that visual appearances really do not correlate with pathology.
And can I, before you go for, so once someone's completed their chemoimmunotherapy, do you just go for a CT scan, or do you want a PET scan?
I don't want a PET scan.
And do you find actually that the CT scan is that helpful? Because often you don't see that much in fact, it can sometimes look dreadful, can't it, within the lung and the nodes? Do you find that that's helpful, or are we just looking for progression?
I just want to know if there's progression. I know it's going to be a nightmare. I already know that. What I want to know is there progression? And in terms of the lymph nodes, I want to know what the pattern of the response has been, what's still bulky and what is not, no longer bulky. And it's really just to kind of predict that, do I need to do a thoracotomy here, or do I carry on VATS? That's all that it
That
matters.
would guide what operation you
Yeah,
would plan based on that CT scan, really.
yeah, yeah. So
And
I go on.
last question for me on this section is, we can see the surgery that was done in the trials.
Yes.
We know lobectomy versus pneumonectomy, for example, R0R1. Um, do you think the surgery that was done reflects real world surgery? And if not, and we touched on this a little bit before, how's it different?
It's unusual to get an R1 for us.
Yeah.
It's certainly not as high as it's been reported in the trials.
Yeah.
If the R1s, to get an R1 on a bronchovascular margin is very, I honestly can't remember the last time I had a
And,
bronch.
and why is that? Why is that the case in bronchovascular margin? Why is that so unusual?
Usually we've made a decision that a tumor is resectable. We've considered that margin. Am I
Right.
going to get bronchovascular and parenchymal clearance? If I'm not, then I'm not going to say that's resectable.
And we should remind people that when you go into the neoadjuvant or perioperative, the decision in the MDT needs to be, the surgeon says, I can do an R0 resection. Well, I believe I
Yes.
can do an R0. And you
Yeah.
should not be going into it to say, well, not now, but if you can shrink it down. That's not the.
No.
I mean,
So this,
there may or may not be a role for that in the future, but at the moment, the commissioned
yeah,
rule is that, yeah.
yeah. So this is one of the consensus. This is one of the recommendations from the consensus statement, that it's operable at the point of diagnosis.
Do you think there's a risk of creep where people start to say, oh, this is induction therapy and I'm going to downstage them a little so that I can
There's no evidence for that. And you shouldn't be doing that as routine practice. Yes, we do see it. And yes, I think you need to be very careful about that situation. They definitely need to be extensively discussed at MDT. And there needs to be, you shouldn't be doing this just kind of off tangent. It's not good care for these patients. If you had significant shrinkage, yes, you may revisit that situation, but ideally the decision for resectability or operability should be made up front.
And just when you're counselling patients about complications and length of stay and things post-operatively, do you counsel them slightly differently compared to patients who haven't had neoadjuvant treatment? Are you seeing longer lengths of stay, longer air leaks, or more complications?
So I generally find if they've had preoperative chemo IO, the post-op window is usually 4 to 6 weeks to get your surgery in. I found going up 4 weeks is too early. They've not recovered fully from the chemotherapy, and that 6 weeks is a better kind of time frame to hit. And I find if you hit that window, then usually your recovery and your length of stay is about the same. Okay. Obviously, where they've had extensive nodal dissection, where they've had a chest wall resection, then yes, the length of stay can be higher and the risk of complications can be higher. So if in a chest wall, I would always consent for a higher risk of post-operative chronic pain. Where I'm going to do extensive nodal dissection, I will consent. I will consent for a chyle leak. I will consent for a chyle leak anyway, but I will make sure that I make a point of mentioning that. Where I've got diaphragmatic involvement or phrenic nerve involvement, I will specifically mention those complications. Otherwise, I would consent as for a general lung resection.
And do you think your kind of experience since you started is much more positive experience in terms of patients you would take on and patients you've seen now have pathological complete responses at the Brompton?
It's I think when we first started doing these patients, everybody was apprehensive, thinking, okay, what you're going to find when you get into the chest here? Because our previous experience of these has been really just the pre-op chemoradiotherapy patients, and which is a nightmare. Okay. And when Tom tries to sell you these patients, walk away. This, but it's actually been very, very positive. So even though I'm kind of questioning life while I'm doing the case, thinking, why am I doing this? Actually, it's been great because you then see them having major pathological response or complete pathological response, and you see them do well, and it's great. So actually, yes, it's a bit more painful, but it's worth the gains because these patients will do better long term.
So in the last couple of minutes, we're going to look to the future. What do you think we have yet to answer? What are the ongoing areas of debate? Or do you think we have our pathways all sorted and this is just going to be how it is?
We don't have pathways sorted. We don't have pathways sorted. What would be the availability of prehabilitation and pre-op optimization I think it's so patchy across the UK. Some centres sound like they have an amazing service, and some centres don't have a service at all.
Yeah.
And the provision and availability of this needs to be kind of available. It needs to be available to all patients, which is just not the case.
Yeah. And in my experience, the areas of highest need are the ones with lowest demand.
Absolutely, for sure. And then having that available for local physicians to deliver. And by this I mean, so it's not so much of a problem if for Chelsea patients, but we have patients from DGHs, and for those patients, the availability of prehab, nutritional support is quite difficult to access this because there isn't a local service, or local service isn't very accessible. So that's the first thing that we need to get right: preoperative optimization and prehabilitation. That needs to be available to all patients. I think in an ideal world, we would see them together, and to discuss the planned package of treatment and what patients need to understand, and to emphasize to patients that this is a complete plan of treatment. You don't get to pick which bits you take and which bits you don't take. You either take the whole package or you don't take any of it. And emphasizing the importance of kind of each of the individual bits. We've had a particular patient who just wanted the surgery but didn't really want the chemotherapy and the immunotherapy, and actually it's counseling those patients that actually the surgery by itself is not curative for you, and you're gonna your biggest problem is micrometastases, which surgery will not manage.
Yeah. And I think one of the challenges we're finding is we then have moved from a neoadjuvant only to surgery to neoadjuvant surgery and then adjuvant, is people have got through the pre-chemo surgery bit, they've got through the surgery, and actually the prospect of another 12 months of immunotherapy is just unbelievably hard.
Yeah.
And we would love to run a joint clinic. It's practically very difficult for us to do that.
It is.
And it's a great shame.
It is. It's really, really difficult because, I mean, we struggle even though we are less than half a mile from each other. Okay, literally up the road.
Yeah.
So I can imagine the challenges oncologists in DGHs face when their thoracic surgeon is coming from, another city. It's quite difficult, and a lot of our work now is done virtually rather than face to face.
Yeah. And I guess last question from me is, the moment we've been clear on we should be doing these neoadjuvant approaches when we know it's resectable, R0 resection, do you think there is a role? Do you think we should be exploring in trials using this regimen as an induction to make someone resectable?
Yes. Yes.
And how should we do that? Should you and I be doing that on a Wednesday evening in our MDT, or should we be doing that formally through trials? He said with a leading question.
We should be definitely be doing it through a trial. There is
Yeah.
no doubt about it. Okay, because there's no trial data. Safety nets our practice, but safety nets protects the patients. Okay, the problem is if you're doing this through MDT just kind of on an ad hoc basis, you're not really going to be collecting data properly, and you can't make decent kind of conclusions from that data.
Yeah. Yeah.
If you threw it through a trial, you get robust data. You can then use that data to treat other patients. I would love to see who can be downstaged and who can't. That would be amazing.
Yeah.
And I think that is definitely the next step. I'm sure the oncologists are already thinking about it. Surgeons are definitely talking about it. It's about how would you conduct this trial? Who should, first off, who should be conducting the trial? And I think if a center wants to be part of a trial, their surgeon and their oncologist says, but both parties have to agree to it.
Yeah. And I think there's very exciting stuff going on. We're going to touch on this in our subsequent podcast, looking at molecular profiling, particular blood profiling. Can you use that maybe to help us make a decision as to who needs surgery when, who needs adjuvant, who doesn't? I think that's going to be fascinating stuff, which we will cover in subsequent podcasts.
So thank you so much, Sofina. It's been brilliant. I've definitely learnt a lot, and I'm sure that everyone listening has as well. So thank you for taking the time to join me and Tom. So next in our series of podcasts, we're actually going for medical oncology. So we're going to be talking to Jason Adhikari about the very confusing world of perioperative and neoadjuvant chemoimmunotherapy. So we do hope that you'll join us for that podcast soon.
Thanks very much, Sofina.
Thank you.
Thank you for listening. We hope you enjoyed this podcast. For more information on BTOG, including educational events and how to join, of course, you can visit www.btog.org. Just to remind you, we would love to hear your comments, thoughts, questions about things we discussed. And for the really interesting ones, we'll even discuss them in our next podcast. You can contact us on info@btog.org or on Twitter @btog.org. Thank you very much.